And then Keith, for your, who gets a DICE in your practice? Like, how do you decide? You mentioned that you typically will try to treat the nose first before maybe even doing the sleep study. What's your thought process?
I personally don't do a lot of DICE because I guess I've been thinking of it in too smaller terms, Ashwin, because I don't do Inspire. I'm typically referring that to either my two partners or there's a couple other folks in my proximity that do a great job with that in other practices. So I think actually I do the awake endoscopy, really looking critically at the nasal airway. I do send a decent amount of patients for CPAP still, but a decent amount of patients for oral appliance therapy as well. I rarely do any pharyngeal surgery outside of tonsillectomy. And rarely do I think of that first line. If I'm doing a procedure first line, it's going to be something nasal and usually a combination. Septoplasty, treating the valve, treating the turbinates, treating the swell body. And I find really anecdotally good results, and there's data to back it up, that even treating chronic rhinitis patients, whether it's allergic rhinitis or non-allergic or vasomotor rhinitis, they do better too because they're not drowning on that mucus all night. The sleep quality is better. The tolerance of CPAP, especially with the nasal delivery, is much better.
Yeah, that one's interesting to me. The like doing a posterior nasal nerve ablation would help with sleep quality. Like I suppose as we kind of talk it through and just talk about it.
The data is good. Yeah, all three technologies that are out there. Of course, there's one cryotherapy, the Clarifix, that's now Stryker, was a company called Aerin. And then there's two radio frequency options, the Aerin Medical one called the Rhinair, and the Neurint, a medical device, the Neuromark, which I personally have not used, but many of our colleagues think highly of that product too. So even just treating the posterior nasal nerve, the data is good that it improves sleep quality. What I do in my practice, and Ashwin, I'd love your thoughts, and Ashley, you too. I choose the Rhinair more often than not because I can also use that to treat the turbinates and treat the septal swell body. And so I love the option of treating the congestion, the actual mechanical obstruction, in addition to the autonomic innervation of the turbinate, making the snot, making the mucus. Others may feel differently, that they get good enough results just with treating the PNN.
Rhinair, as far as PNN treatments and chronic rhinitis treatments, allergic or non-allergic rhinitis, the Aerin Medical, the Rhinair, is my favorite. I was a very, 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 very skeptical at the beginning because I hadn't done it in residency. I hadn't done it in fellowship. Residency and fellowship, I did Clarifix, and we did, as a counterpart to the Vivair, we did full rhinoplasties or functional rhinoplasties a lot. So I had no experience with Neuromark or Rhinair or Vivair coming into practice. And it's funny, my local rep reminds me the first time I ever did one, I was pretty nervous. And I said, look, I just don't want to kill this person. And he laughed at me. And now I love offering it because it's so safe and it's very effective. The effectiveness has blown me away because of how easy it is to do.
It's quick.
And how happy the patients are. It has helped me not think twice about offering it. The reimbursement was great. Now it's good, which only helps. But the ease of recovery for the patient, they get up out of the chair and they walk out and they drive home. And the effectiveness, which has been very, very, very favorable, and the safety, knock on wood, I haven't had a single serious complication, has been fantastic. So in terms of PNN treatment, I totally agree. I think it has something to do with postnasal drip and like retained secretions in the tongue base or the pharynx of something that triggers some kind of cough or gag reflex and wakes you up. That's my personal theory on why the PNN treatment helps for that. But you're also doing the turbinates and the swell body also. So maybe it's something about nasal flow and airway obstruction coupled with that. I haven't done PNN treatments alone, and I haven't done anything other than the Rhinair in practice, other than like one Neuromark.
In fairness to the other two, I mean, I prefer the Rhinair because of the being able to treat 3 spots, but the data is good on patients' perception of airflow. I know with the Clarifix, and I would presume with the Neuromark too.
So that's the outcome that they're looking at is like nasal, like airway scores, or like is there
Yeah, exactly.
did they
Whether
look at
it's the
sleep?
SNOT 22 or other TNSS, whatever, patients feel like they're moving more air with all of it. And that's got to be helpful for OSA, right? It's got to be helpful.
I'm going to bust out some physics. The radius to the fourth power, right? So the radius to the fourth power, what that means to me is that a tiny increase in the nasal airway will impact flow exponentially. And my correlate is like subglottic stenosis, and that classification of subglottic stenosis where it's like the child has no symptoms, and then all of a sudden the child has stridor and problems. I think the nose is the same way. You have a threshold at which you perceive nasal obstruction, even though there is some flow. If you get above that threshold, then whether that be with just a tiny little radio frequency, or that be with bony surgery or mucosal with real operative surgery like we do, you get above that threshold and the flow gets to a point where the patient doesn't perceive nasal obstruction anymore. So that's my physics theory.
That's a really, I'm glad you brought that up. That's not too scary physics. I can understand that at least. And I say that 10 times a day, is that if I give you 2 millimeters, you're going to feel like I opened your airway 16 millimeters. And patients really do. And that's what's been fun for me to see the evolution. Now, you guys trained when there already were office procedures, but I didn't. And so seeing that really come to fruition in 2011, the difference when patients could tell us in the chair, well, doc, whatever you just did, even if I ballooned a maxillary sinus or whatever, seeing that Bernoulli principle in real life, the second I took the balloon out, so whatever you just did, I can breathe better. It's like you're holding a fan up to my nose. And to the point, I used to think it was a placebo or it was the Aerin, but we now know, no, that's actually true. We're taking a 2 millimeter os and making it 6 millimeters. The patient feels that right away. And I think it's the same with these treatments of the turbinates and the swell bodies.